Hi everyone, my name is Brett Kurpiel. I am a PGY3 Anatomic and Clinical Pathology resident here at the University of Virginia, and I want to say thank you for taking the time to listen to my talk. So my interests in pathology lie in perinatal and placental pathology, and so today I'm recording a talk that I gave at the Virginia Society for Pathology entitled More Than Just Choreo, Placental Pathology for the General Pathologist. So let's go ahead and get started here with a case. So we'll start with an autopsy case. The mother is a 36-year-old G2P1001 who noticed decreased fetal movement at 34 weeks and 2 days, who presented to labor and delivery. She had an overall uncomplicated pregnancy. However, when she came in, no fetal heart tones were detected. Now, she consented to a full autopsy with no restrictions, and at the time of autopsy, there were no gross or histologic abnormalities of the fetus itself. So, whenever we think in the world of perinatal autopsy, when we come across a fetal autopsy with no anatomic cause of death, the next thing we have to think about is the placenta. So we do a full placental exam for vascular compromise, infection, anomalies, etc. And today we're going to be mostly talking about vascular lesions of the placenta. And so if we identify some sort of vascular compromise within the placenta, we have two main camps. The first camp is when we have issues with getting oxygen from the uterus to the placenta, which is termed maternal vascular malperfusion, or issues from getting oxygen from the placenta to the fetus itself, which is termed fetal vascular malperfusion. So at the time of placental examination, we saw areas of vascular ectasia, scattered villus stromal vascular karyarexis, and basement membrane ferruginization, numerous avascular villi, a partially occlusive chorionic plate thrombus, as well as markedly increased circulating nucleated fetal red blood cells, all of these findings of which are compatible with fetal vascular malperfusion. Now, if all of those histologic findings were a little bit of a whirlwind or kind of confusing to you, then you're in the right spot. Today, we're going to talk about fetal vascular malperfusion and maternal vascular malperfusion. So first off, to start with, I want to discuss the Amsterdam criteria. So the Amsterdam criteria come from this article, Sampling and Definitions of Placental Lesions, the Amsterdam Placental Workshop Group Consensus Statement. And this is where I get all of my diagnostic bottom lines from and my kind of ways to approach a placenta. So ideas of maternal vascular malperfusion and fetal vascular malperfusion, I use the Amsterdam criteria. So let's start off talking about issues with getting oxygen from the uterus to the placenta itself. This is termed maternal vascular malperfusion, also called uteroplacental insufficiency. So gross findings in these cases of MVM include small for gestational age placentas, which is actually a diagnostic requirement for diagnosing MVM. You can also see scattered infarctions in areas of retroplacental hemorrhage. Now, if you look here in this picture here on the right, we have the placental plate. Now, above it, this is the fetal side and this is the uterine side. Above it, we have an area of hemorrhage. And this hemorrhage is actually compressing the plate and pushing the plate down. This was the case of a fetal or a placental abruption. And so placental abruption where blood can accumulate beneath the plate and push and compress the placental parenchyma is associated with MVM. Now, microscopic findings of MVM include what is called decidual arteriopathy, which we'll get into in a minute, accelerated villus maturation, distal villus hypoplasia, and then similarly, as we see grossly, you can see areas of hemorrhage and infarct. So here we go with some histologic findings of maternal vascular malperfusion. So this is a close-up of a decidual artery. You can see we have some decidual cells in the background, and here is an artery here in the decidual plate. Now, the first thing you notice is that this artery is markedly thickened. We've got kind of full thickness here of inflammatory cells and a buildup of fibrin within the wall. Additionally, you have these foamy histiocytes present in the wall. This is called atherosis. And this is an example of decidual arteriopathy. What happens here is the decidual arteries are not remodeled properly at the time of placentation, and we get kind of thickening of the arteries instead of the nice distended thin arteries that you should see in a properly modeled placenta. So going a little bit on the lower power next, we can see here we've got the membrane roll. Now, when I look at a placenta, I always look at the membrane roll to look at my decidual arteries. You might think that the disc would be the best place to look, but I find the decidual arteries actually come off best on the membrane roll itself. And so up here on the top of the picture, we have normal membranes, but down below we have decidua. And you can see these very thick walled vessels showing marked fibrinoid necrosis. So this is consistent with decidual arteriopathy. And then just to go a little bit higher, you can see we've got thickness here of the vessel wall itself. And off to the side here on the right, you see this very thin walled, almost inconspicuous vessel. This is a normal and appropriately remodeled decidual vessel. So all of these should look more like this. When you see these thickened vessels from low power, make sure to go higher and look to see if you can see areas of fibrinoid necrosis, or you can see thickening and retention of the smooth muscle, which should disappear as the placenta implants into the decidua. Next up, we have the term accelerated villus maturation. So in general, as the villi mature with gestational age, they should get smaller and smaller. You also get increase in what is called syncytial knotting. So what happens as the placenta matures is the syncytial trophoblasts lining the outside of the vessels start to heap up on one another and form these so-called knots, as you can see here, these big groups of nuclei here. And so what they're doing is trying to basically get out of the way of the fetal red blood cells inside the villi and the maternal red blood cells outside of the villi. And the purpose for this is to create as little space between the two cells as possible to facilitate gas and nutrient exchange. However, in fetuses where oxygen is not readily getting from the uterus to the placenta, you can have this acceleration of the maturing of the villi, where you get increased syncytial knotting. You get very small syncytial knots that almost appear like they're floating in space. This is a third trimester placenta, and this is way too many syncytial knots for a third trimester placenta. Now, oftentimes what goes hand in hand with accelerated villus maturation is what's called distal villus hypoplasia. So looking at the fetal surface of the placental disc, you'll notice in normally mature placentas, you'll see areas of fibrin deposition. However, in placentas that are small for gestational age with features of maternal vascular malperfusion, you can oftentimes see this hypoplasia. These villi are extremely small, terminal villi are extremely small and puny. You can't really get much maturation here. And again, we've got those kind of floating syncytial knots here. Some of these villi don't even have vessels, like this one over here. And so this is called distal villus hypoplasia. So all these findings together, accelerated villus maturation, distal villus hypoplasia, a grossly small placenta with infarcts, these are all consistent with maternal vascular malperfusion, which is oftentimes the histologic correlate to what is called by the clinicians as preeclampsia or maternal hypertension, whether it's chronic hypertension from before pregnancy or just gestational hypertension. So that's one vascular lesion with issues from getting blood from the uterus to the placenta itself. Next, we'll focus on issues getting blood from and oxygen from the placenta to the fetus, so-called fetal vascular malperfusion, or FVM. So fetal vascular malperfusion, some gross findings include namely some cord lesions. You can see knots, such as this true knot here on the right. You can see areas of thrombi within the vessels itself, or even cord avulsion. Oftentimes you'll see chorionic cysts and pseudocyst formation, and you additionally can have areas of infarction. Now, microscopic findings of FVM include areas of intramural thrombi, or intramural or intravillous fibrin deposition, avascular villi, and the term villus stromal vascular karyarexis, or VSVK. So let's get into it. For fetal vascular malperfusion, here we see a low power image of an umbilical vessel, and you can see completely filled within the vessel is a thrombus. You can see fibrin deposition and then inflammatory cells embedded within the fibrin itself. So this is an example of a full thickness clot within a fetal vessel consistent with fetal vascular malperfusion. Additionally, like we had in our case, and this is actually a slide from that case, when you go and look at some of the chorionic plate vessels or some of the vessels closer to the disc, sometimes you can see areas of organizing fibrin and clot at the periphery of a vessel. While it might not be full thickness and completely obliterating the vessel, you can see these areas of organization, which is suggestive of fetal blood stasis. Additionally, when you look at this image from low power, after you've looked at many, many placentas, you might start to get the idea that this placenta, it's a little bit too pink here at low power. And so that should prompt you to go a little bit higher. And when you go on higher power, you see we've got areas of intervillous fibrin deposition. And when you take a look at the villi themselves, you'll notice they are completely avascular. So this is a consequence of upstream cessation of blood flow, whether it's due to a thrombus or some sort of physical compression, intermittent cord compression, or a knot itself. When blood is not flowing through the villi, they become avascular, and the stromal and endothelial cells actually start to die off. The process of which they die off is termed villous stromal vascular karyorrhexis, which is what we see here. When you take a look at high power on some of these villi, you'll start to see some karyorrhectic and apoptotic debris within the villi themselves. You can see this villus here. It's kind of a middle-sized villus, not quite to a terminal villus, but you can see that it is mostly avascular, maybe a little vessel holding on over here. Most of it is completely obliterated, and you see these areas of apoptotic debris. And then you can also get this kind of eyeliner sign underneath the basement membrane, termed basement membrane subferruginization. And so you can also see over here, we've got increased calcifications, we've got some more apoptotic debris in this villus. And so villous stromal vascular karyorrhexis is the process through which the villi undergo death and become avascular. So this is a little bit of an earlier finding that you might see in a kind of an IUFD picture. And then this is a softer sign that you'll see in some of your placentas. But if you look very closely at this placenta here, you'll notice there are nucleated fetal red blood cells within the villus circulation. And so when you see an increase in nucleated fetal red blood cells, that indicates fetal stress. And so that's kind of a soft sign here for fetal vascular malperfusion. And then lastly, something that is, again, another soft sign is vascular ectasia. And so when you look and see the vessels that are dilated, it should be approximately 4 times the size of a normal vessel. That is indicative of some sort of clot or some sort of stasis in the vessels downstream. And so for fetal vascular malperfusion, additionally for maternal vascular malperfusion, these are kind of exist in a constellation of findings. One finding by itself does not merit a diagnosis of FVM or MVM, but rather you have to see all of these findings in constellation as well as the proper clinical picture to determine a diagnosis of FVM or MVM. Now, something that is really tricky for general pathologists and even perinatal pathologists alike is kind of teasing out the differences between fetal vascular malperfusion versus intrauterine fetal demise changes. The problem with this is that they both look exactly the same. So there's significant overlap between the histologic findings of FVM and changes associated with IUFD. The most important thing when I'm approaching a placenta is to consider the timing of the IUFD. Is it first trimester, second trimester, or third trimester? First trimester losses, if you see these changes of fetal vascular malperfusion, it's most likely due to IUFD-like changes. And that's because the majority of first trimester losses are going to be your chromosomal abnormalities. And so most of the time, there isn't necessarily a problem with getting blood or oxygen to the fetus itself, but rather there was just chromosomal abnormality that caused things to form incorrectly and caused some sort of IUFD or abortion. Now, when you think about your second trimester causes, you can start to get into some placental insufficiency. However, the majority of these causes are going to be infectious in nature. So you want to consider your chorioamnionitis, your torch infections, things like that. Now, third trimester is where we start to get into the area where the overlap between FVM and IUFD. Third trimester losses, about a third of the time, can be contributed to placental insufficiency. Now, the majority of the time, the placental insufficiency is going to be due to maternal vascular malperfusion, but some of the time it's going to be due to fetal vascular malperfusion, due to cord compression, knots, cord avulsion, things like that. And so we have to start looking at the histologic features to tease that out. So villostromal vascular karyarexis and avascular villi in FVM and IUFD, they both occur, and it can be really hard to determine whether the VSVK and avascular villi are just because of the IUFD-like changes because of fetal stasis, or was it caused by fetal vascular malperfusion, which then led to IUFD. The key here is you're going to look for the pattern of VSVK and avascular villi. If the findings of VSVK and avascular villi are in a patchy or segmental pattern, or they look temporally heterogeneous, that is more indicative of a fetal vascular malperfusion finding. If everything is global and kind of looks at the same stage of VSVK and avascular villi, that is more consistent with changes of IUFD. And so that's kind of the key feature here. You're also going to want to look for true thrombi. If you see a true thrombus, that is definitely caused by fetal vascular malperfusion and not IUFD. You should not see true thrombi in cases of IUFD changes alone. And then the last thing that really helps is not actually a histologic finding, but one that you see on external exam of the fetus, and that's fetal desquamation. So I took this chart from the Diagnostic Pathology Placenta book, where they discuss the findings of fetal desquamation and how they relate to IUFD timeline. So you can see here, when you have desquamation of less than 1 centimeter of fetal skin, that's associated with a post-demise interval of about 6 hours. And all of these findings here have really great sensitivity, specificity, and positive predictive value. And it just kind of increases as you go along. Desquamation of the face, back, or abdomen is associated with about 12 hours of post-demise interval. Over 5% of the body surface is greater than 18 hours. And then additionally, desquamation of over 2 of the 11 zones, which are described down here, is associated with over 18 hours, and then frank mummification of the fetus is associated with a post-demise interval of 2 weeks. So incorporating your histologic findings as well as your gross findings at the time of autopsy, you can come up to a conclusion whether the VSVK, the avascular villi, and things like that that you see in the placenta are because of fetal vascular malperfusion causing IUFD, or is it because of another entity causing IUFD, and those associated changes are just because of the nature of intrauterine fetal demise. So in summary, we have maternal vascular malperfusion and fetal vascular malperfusion. For maternal vascular malperfusion, your clinical considerations are going to be preeclampsia, chronic hypertension, intrauterine growth restriction, early intrauterine fetal demise, and also preterm premature rupture of membranes. Gross findings will be placental hypoplasia, so small for gestational age placenta, areas of scattered infarction, and also hemorrhage. Histologically, you're going to see findings of decidual arteriopathy, infarctions, accelerated villus maturation, and distal villus hypoplasia. For fetal vascular malperfusion, some clinical considerations include late-term IUFDs, a fetus born with low AFGARs, stillborn or so-called cord accident. Gross findings include cord lesions, infarctions, and cyst formation. And then histologically, you'll see your avascular villi, thrombi within the cord and chorionic plate, villostromal vascular karyarexis, areas of infarctions, and dilated vessels or vascular ectasia. So why should you care about placenta? Obviously, I care about the placenta because I'm a huge nerd, but understanding placental pathology is vital for any general surgical pathologist. You know, anywhere you go, you're going to see placenta. Anywhere you train, you're going to see placenta. And oftentimes, placental pathology is a part of training that is easily overlooked. I equate placental pathology to any type of medical pathology, whether it's medical liver, medical lung, or medical kidney. It can have significant implications for the fetus as well as the mother. And correctly diagnosing these placental pathology has numerous benefits. So we can help understand adverse outcomes in pregnancy for both the clinicians and families. We can help clinicians anticipate proper management for future pregnancies. Some of these findings are often recurrent. We can elucidate antenatal events that may have permanent neurologic sequelae, findings of fetal vascular malperfusion at the time of delivery leading to hypoxic ischemic encephalopathy, things like that. And then also what is really important is we can provide proper documentation for medical legal purposes if something were to come up later. So I hope that you guys took away some good knowledge from this placenta lecture. I want to say thank you so much for listening.